Hello, I'm Tak Lok and one of the respiratory physicians based at Tunbridge Wells Hospital. We are in the midst of a severe coronavirus outbreak, and many of you have volunteered to support our frontline staff in managing patients with the condition. Some of you may have felt a little nervous or concerned about the skills to interpret the chest X-ray in these patients. Over the next 10 minutes, I hope to tell you all you need to know about chest X-rays in the coronavirus era. Firstly, some words about infection control. Most of you will have seen that our X-rays are now done by portable machines to minimize infection risks to staff. At all times, proper PPE precautions should be taken in tending to patients with COVID-19 infection. Where films or imaging from the department are required, patients are required to, as a minimum, wear a face mask during the transit. Firstly, let me refresh your memories about the normal chest radiograph. This is a chest film of a normal, healthy adult. You can see that the film is well penetrated and centrally placed. The patient has taken an adequate inspiration where you can count normally 10 ribs posteriorly on either side or 8 ribs anteriorly. The mediastinal and hilar structures are well visualized, and both diaphragms can be seen to the costophrenic angles, which are normally crisp in the absence of any effusions. The apices should also be visualized, and in this case is clear. There's a gastric bubble, which is normally placed just below the border of the left hemidiaphragm. Here, the normal X-ray has superimposed upon it the anatomical structures that you are familiar with. On the right side, the brachiocephalic vein communicates with the superior vena cava, which then links to the right atria, the border which should be clearly seen here. On the left side, the mediastinum is made up of the aortic arch, which borders with the left pulmonary trunk, the left hilum, which is in continuity with the left atrium and thereafter the left ventricle. The right lung comprises 3 lobes: the right upper lobe, which borders with the right middle lobe and is separated by the horizontal fissure. This fissure can sometimes be seen on a normal film. The oblique fissure separates the right middle lobe from the right lower lobe, which is occasionally seen on the plain radiograph. The left lung is made up largely on the PA film by the left upper lobe, with a smaller proportion of the left lower lobe seen in the inferior region. Diseases that affect the lungs will often obscure the adjacent border of a structure, also known as the silhouette sign. So, the chest X-ray findings on COVID-19 patients. It is worth pointing out that the X-ray can be normal, particularly at the initial stages of the disease. However, as the condition progresses in severity, there are progressive changes that are noted on the chest X-ray. 3 patterns have largely been described notably an asymmetrical or patchy consolidation, diffuse airspace opacification, or an ARDS pattern. Over the next few slides, I hope to show you examples of these and how to recognize these appearances. This is a good example of a patient who presents with diffuse airspace opacification in the right upper zone, as well as some minor changes on the left. Here, you will see a confirmed COVID-19 patient demonstrating patchy consolidation in the right midzone. There is also change on the left midzone, and there is clear consolidation in the left lower lobe as the left hemidiaphragm is completely obscured. This is a typical chest radiograph of a patient who has developed acute respiratory distress syndrome. On the film, you will see patchy bat wing and confluent opacification emanating from both hilar and sparing the costophrenic angles. This appearance can also be seen in patients presenting with acute pulmonary edema, although there are usually other ancillary findings on the chest radiograph. This is an elderly patient who presented with a high fever and cough. His chest X-ray on the first day showed some patchy changes of consolidation abutting the horizontal fissure on the right lung, as well as some other changes in the periphery of the left lung. The patient deteriorated rapidly, and on day 2 required intubation and mechanical ventilation. Here you will see his chest radiograph showing consolidation largely in the right upper lobe, as well as some additional consolidation and diffuse opacification on the left upper zone. The patient has an ET tube as well as a central line in situ. CT is more sensitive than chest X-rays in detecting lung involvement, particularly at the early stages of this disease. It is, however, often limited in availability and has the risk of increased radiation to the patient. There are some characteristic findings which I have outlined here. These are described as a peripheral distribution of ground glass opacification, sometimes associated with increased bronchial vascular thickening. The other features which are less likely to be found in COVID-19 confirmed patients include mediastinal adenopathy, pleural effusions, and lung nodules. Pneumothoraces have also been reported as less likely to be associated with this condition. Lung ultrasound is now gaining greater acceptability amongst ED and respiratory physicians in the assessment of early COVID-19 infection. The ultrasound has the added advantage of being able to be performed by the patient's bedside with no additional radiation exposure, both to staff or the patient. In addition, serial imaging allows for close monitoring of patients at risk of deterioration. Patients with normal chest X-rays and the absence of any characteristic features on ultrasound may be discharged for early follow-up. Some of the classic features on lung ultrasound have been described here, and they closely correlate with CT findings of the chest. Availability of this imaging is currently limited by local expertise. in summary, I hope to have shown you that chest X-ray interpretation is really about pattern recognition. And we can all do this and develop greater familiarity that will help to guide our decision making in this time. However, a normal chest X-ray does not exclude COVID-19 pneumonia, and sometimes chest X-ray features will lag behind the presentation of clinical symptoms. CT is clearly a more sensitive imaging modality than chest X-ray, but the access to this service is limited, and it carries with it a greater radiation exposure. One should consider, therefore, bedside ultrasound imaging as a point of care test if local expertise is available. I hope you have found this short video blog useful. I wish you all the best. Stay safe. Keep well.